بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Dear students, good morning. Today's lecture is about GIT imaging. We'll stress on the topics that are related to cancer of GIT. I'm Mosab Shetiwy, lecturer of surgical oncology, Mansour University. In this topic, we'll be talking about the plain abdominal X-ray, plain X-ray of the abdomen. That's the X-ray of the abdomen without dye. We'll have a quick look on the CT with contrast, CT colonography, and a few slides about MRI and EUS as well. Well, actually, radiologists are like professional pilots. They depend on the vision to diagnose problems or to do their job. However, radiologists are unlike pilots in that they are not required to undergo regular vision testing. Anyways, if you can distinguish Mark Simpson wearing sunglasses in this slide or photo, you will probably pass a radiology test. So, as we've mentioned, imaging of the GIT might be done without contrast, like as we've mentioned, we'll be mentioning in more details in this lecture. Plain abdominal X-ray. It's just like the chest X-ray, but it's an X-ray in the abdomen. And sometimes we add a contrast material, and in this instance, it will be called an X-ray with dye or fluoroscopy, like the ones we do for upper GI, barium swallow and meal for esophagus and stomach respectively, barium follow-through for small intestine, and barium enema for the large intestine. And the X-ray with dye will be discussed in another lecture, inshallah. Plain abdominal X-ray, like any X-ray film, will be having different radiologic densities ranging from hypodense lesion or hypodense opacities to hyperdense opacities or white opacities. Actually, we're interested in showing the densities, abnormal densities of air and calcium, and these will be discussed in this lecture. First, we should know that plain abdominal X-ray is taken in different views, in a supine view, in an erect view, and sometimes a patient may attain a certain decubitus or position to reveal an abnormality in some instances, a few instances actually. But overall, the supine X-ray of the abdomen is the most commonly reported or wanted investigation, as well as the erect. You should know that the plain abdominal X-ray exposes the patient to a radiation dose that is equal to about 75 times the one that is exposed when he's doing chest X-ray. So that's a high dose, okay, of X-ray radiation. Of course, plain abdominal X-ray is absolutely contraindicated in pregnancy because there is no way you can prevent the X-rays from reaching the pelvis. During abdominal X-ray, you should image the abdomen and the upper and the pelvis as well. So if the patient is pregnant, that's absolutely hazardous. For an abdominal X-ray film, you should know that there are normal densities that you may be encountered with when reading an X-ray of the abdomen, like the presence of normal gas, which is found in for example, the stomach. Okay, maybe air fluid levels are also seen in the stomach, the transverse colon, and the duodenum. So multiple air fluid levels up to 3 are supposed to be normal in an X-ray film of the abdomen. But as regarding the center, for example, in this film, there is a gas in the small intestine filling the lumens of the small intestinal bowel or segments, and that's normal. Sometimes when you are having X-ray of the abdomen with dilated stomach, the regie of the stomach might be present, and that's normal. The normal feathery appearance of the jejunum or jejunal wall in the human is also seen in an X-ray film. And lastly, air inside the colon will show hostrations, but these hostrations are incomplete. Incomplete hostrations of gas inside the human denotes that this is a large intestine, not a small intestine. Because small intestine, as we've seen with the jejunum and ileum, the valve convenience cross the entire bowel lumen from one side to another, but become incomplete in the colon. As I've mentioned, the X-ray of the abdomen gives the patient radiation dose about 75 times that of the chest X-ray. Actually, radiation is measured in sieverts or microsieverts, which is the unit of dose equivalent of the biological effect of ionizing radiation. As you can see, chest X-ray gives or exposes patients to 100 microsieverts. A mammogram is 400 microsieverts. The CT or CTC, the colonography, CT colonography, exposes the patient to a very high dose of 10,000 microsieverts. That's very big. It's about 100 times chest X-ray. So it's important that you do not repeat the imaging because unless indicated or absolutely indicated, because this exposes the patient to further radiation that's beyond the allowed doses yearly. On a normal plain abdominal X-ray, you may be encountered with such a film. And actually, in this film, if you zoomed in, you'll find different shadows that should be explained. Like, for example, on the upper left and right in the peripheries, there are densities of air or gas inside the large intestine. So large intestinal gas is distributed peripherally, okay, and centrally or in the center. If you can see shadows of air in the center, this denotes air or gas in the small intestine. If you can see or follow the small black arrows on the right and on the left of the vertebrae, there should be supposed to be a line. It's called psoas shadow. This is a shadow for psoas muscle. Just lateral to it, to the right and the left, it should be the kidneys. Again, this is a normal abdominal X-ray, and you can see the shadow of gas filling all of the large intestine. It's like large intestine is being drawn by gases. It's very clear. Gases in the cecum, the transverse colon, and the left colon, even the sigmoid downstairs. Sometimes a plain abdominal X-ray may demonstrate different structures or different shadows of abnormal materials, like the ones present in this film. There are cables that are inserted across the patient's chest and upper abdomen, and you may have guessed that these are cables of the ECG. So you may be encountered with such a film and not be estranged or perplexed because, for example, this patient is a patient in the ICU and she's doing an X-ray of the chest and abdomen with the ECG connected to her. So what are the indications of the plain abdominal X-ray? Actually, there are many indications, but we are concerned surgically with those patients who are presented with acute abdomen or unexplained abdominal pain, which may be related to perforated viscous or perforated malignant condition, and of course with patients with query intestinal obstruction. And of course, abdominal X-ray is not the first line of investigation in a patient presented with trauma to the abdomen, penetrating trauma, and not for solid organ assessment. In those conditions, we order other measures or imaging modalities like fast scan or even CAT scan or CT. So let's get back to the topic of our lecture, the abnormality in an abdominal X-ray. We've mentioned that we'll be looking at two abnormalities in gas patterns and abnormalities in calcium distribution all over the abdomen and pelvis. First, we'll start with the abnormal gas patterns. The gas or abnormal gas may be present within the lumen of a bowel, small or large bowel, may denote obstruction proximal to this area, or gas abnormal gas present outside the lumen, that is gas freely present in the peritoneum, which is called pneumoperitoneum, which may denote perforated viscous, or within a cavity, localized within a cavity that might denote an abscess if it is associated with a fluid level. So let's start with causes of abnormal intraluminal gas. We've mentioned that it's either associated with large or small intestinal obstruction. You should know that the intestinal obstruction has many causes, but the big four causes of intestinal obstruction: adhesive intestinal obstruction, secondary to surgery. The second one is hernia, strangulated external hernia. Third is colorectal neoplasia or carcinoma of colon or rectum. And lastly, paralytic ileus. Others mainly paralytic ileus. Of course, bowel obstruction is mechanical obstruction of the lumen of bowel, causing stasis of the bowel contents above this obstruction. So the bowel proximal to the site of obstruction will be dilated, distended with fluid and air. And this is what we find abnormally on an X-ray film. This is an excerpt from the textbook of radiology by David Sutton. It says that no abdominal radiological examination is complete without a film taken to demonstrate the lung fields. And it means that when you're doing an abdominal X-ray film, you should take cuts in the chest, the upper and lower chest, as much as possible to delineate any pulmonary or cardiac problems, because these problems may cause acute abdomen and may enter in the differential diagnosis of acute abdomen, so that you're thinking that your patient is having acute abdomen due to an abdominal cause, but actually he's having a chest problem, and you've missed that because you haven't had cuts or you haven't had the lungs or lung fields examined during doing the abdominal film as well. Moreover, this is a quotation from the Abdominal Plain Film Bible by Stephen Baker. It says that there is, as long as there is sufficient gas in the bowel in the supine view, and this sufficient gas is adequate for determining the site of intestinal obstruction, there is no need to do an erect film, because an erect film in a sick patient will be unnecessary and it will cause unnecessary pain and rigor, and takes time. So it's okay if you omitted the erect film in a sick patient, a very sick patient, if you could with a supine film know the site of obstruction. So we're doing a plain abdominal X-ray film for a patient with query intestinal obstruction. So we're looking at a dilated bowel, with a large or small bowel. We have to know the 3-6-9 rule. That's 3 centimeters, 6 centimeter, 9 centimeter rule of dilated bowels. These are the normal maximal diameters of the small intestine, the colon, and the cecum. So if the small intestine is dilated beyond 3 centimeters in an X-ray film, this means that this part of the bowel is abnormally dilated. That is 3 centimeters for the small intestine, the jejunum or ileum. If any part of the colon except the cecum is dilated beyond 6 centimeters, this means that this is an abnormal dilatation in this segment. And because the cecum is the most capacious part of the large bowel, it can take gases normally up to 9 centimeters, but if extends beyond or dilates beyond this, it would indicate or denote an obstruction distal to this dilatation. We'll apply this rule in the next film. But let's start with the small bowel obstruction. There are signs in the plain abdominal X-ray of the small intestine that indicates the obstruction. As we've mentioned, if the dilatation is beyond 3 centimeters, if there are multiple air fluid levels in the small intestine, or if you can see more than 3 air fluid levels, especially in the central region, as we mentioned before, 3 are normal for stomach, duodenum, and transverse colon. And there are other couple of signs like the slit sign, the string of pearls sign, and coiled spring sign, which denote, if they are present, definitely denote small intestinal obstruction. So let's have a look at the normal air-filled small bowel. As we've mentioned before, the small intestine occupies mostly the central part of the abdomen. So if you're given this film, this comment on this film, this is a plain X-ray of the abdomen. It shows the mid part of the abdomen with the vertebrae in the middle and shadows of the pelvic bones at the lower lateral ends of the film, and the ribs at the upper ends. There are shadows of gases inside in this film, the center of this film, and actually with the white arrow, the small bowel is drawn by this gaseous shadow, but the which shows also dilated small bowel, but the dilatation is about 3 centimeters. So this is abnormal gas. This is normal gas pattern inside the small intestine. Well, actually, this look is or has been linked to a crazy bathing with a pattern on a giraffe, as appears as interlocking random tessellated pattern of gas distribution in the small bowel, and that's normal for gases in the small bowel because we always ingest air and so on, and that is normal. There is no dilatation beyond the limit that we've mentioned. When there is small intestinal obstruction, let's consider this look intraoperative. The surgeon's hands are at the site of obstruction. Proximal to the obstruction, the small bowel is dilated, distended and filled with air, and distal to it, the small bowel is collapsed and empty. And that is what we see intraoperative. But before that, we can expect the small bowel obstruction with the following views. As we've mentioned, small bowel obstruction in the abdominal X-ray film is present in with different signs, especially in the erect film, the air fluid level. So if you're encountered with such a film, you should never say that this film is in the supine position, because you can see air and fluid. Fluid is giving the horizontal leveling of the shadow of the gas, and air is above, the fluid is below. Okay, so and the densities of air and fluids are different, a little bit different, like the ones in the middle. So multiple air fluid levels that may take the form of a step ladder. Will be showing a typical step ladder in next. But anyways, so this to get this position, to get this view, the patient must be in an erect position so that air will fly up and fluid will be leveling below. So air fluid levels at multiple air fluid levels at different heights within the center of the abdomen always denotes small bowel obstruction. So if we would like to comment on this film, this is a plain abdominal X-ray taken in the erect position showing abnormal multiple air fluid levels in the center. It might denote small bowel obstruction. Again, an erect radiograph of the abdomen. That's X-ray without dye or plain X-ray, showing multiple air fluid levels, and actually, like in the black arrow, the valve convenience of the small bowel are completely crossing from one side to another, and this denotes that the dilated bowel that contains air and fluid within is definitely a small bowel, not a large bowel. Okay, so let's skip this one, it's a little bit difficult. And yeah, very good. So this is a typical photo or image of or film of small bowel obstruction. As you've mentioned, it's either air fluid levels, dilated small bowel beyond 3 centimeters, or one of the signs that we'll get in a minute. With the dilated bowel beyond 3 centimeters, like this one, almost 5.5 centimeters, the valve convenience are closely spaced because the small bowel is maximally dilated to a level that these valve convenience form a sign called spring coil sign. It's like a spring, coiled spring, and this denotes small bowel obstruction. That's exclusive for small bowel obstruction. So again, it's very clear. Yeah, this is small bowel obstruction. Small intestinal bowel segments are seen in the upper left corner. That denotes small bowel obstruction. This is a very clear image, again, of the small bowel obstruction with coiled spring sign. The next sign that you might know is the string of pearls, عقد اللؤلؤ. When you connect pearls together to a string and you see it from afar, you'll see only the pearls, okay, and that is what we can see with the white arrows. And actually, this is diagnostic of obstruction of the small bowel. Okay, this sign that's seen above or in front of the white arrows is called the slit sign, where air is trapped in the valve convenience, which are filled with fluid, causing trapping of air on one side or either side along the valve convenience, causing the slit sign, which denotes also small bowel obstruction. Okay. Now this is a very clear image of multiple air fluid levels of a plain X-ray film taken in the erect position, and it's actually showing also in front of the white arrow the small beaded appearance of the string of pearls sign, as well as the stepladder of multiple air fluids all around the center and the peripheries of the small bowel, denoting obstruction. Okay. So let's take this film. It's for a 70-year-old lady who presents to the emergency department with abdominal pain and distension, and she actually reports history of bowel cancer. If you examine the film, you will see that there will be in the center and the periphery around the vertebrae, um, there is a stretch sign which denotes fluid-filled small bowel trapping air on one side of the valve convenience, and this denotes dilatation of the small bowel with distal obstruction to this small bowel. Again, this is a film showing the string of pearls sign of air trapped within the small intestine, which is exclusive for small bowel obstruction. As for large bowel obstruction, you should know that there are normal appearances in a large bowel X-ray film produced by hostrations and saculations, especially within the right and transverse colon segments. With moderate distension, the plicae extends across the lumen incompletely, but with severe distension, there will be no plicae at all. And the more widely spaced plicae, the more the distension is. And of course, compared to the small intestine, the plicae are actually more widely spaced than the valve convenience of the small intestine. So if you've seen a structure within the X-ray film showing widely spaced plicae, then this is a large intestinal segment, not a small intestinal segment. As you've seen previously, the valve convenience are less widely spaced; they are closely related to each other. Okay, so this slide shows differences between small and large bowel radiologic appearances. Actually, in this small bowel, there will be, as we've seen previously, shadows of liquid or fluid and gas or air and fluid only. We don't see solid material like we can see sometimes, or yeah, I mean, it's uncommon actually in the large bowel. So any shadow of solid shadow within the large bowel, this denotes usually feces, and this is exclusive for colon or colonic segments or large intestine. Also, you should notice that the abnormal gas pattern that you're looking for. If it is peripherally located, then that is always large bowel, except the sigmoid, which is seen in the pelvis, okay, in the midline, the pelvis. Okay, so this is that's air in the large and small bowel. Of course, large bowel air is denoted or seen in front of the white arrows. It's like it's been drawn, right colon transverse and the left, and it's the peripheral or periphery of the film. And in the center there is the small bowel um, normal gas distribution. Okay, and of course, if you want to comment on this film, you would say that this is a plain abdominal X-ray showing the abdomen and the pelvis and upper thighs on each side. Um, there is gas distribution in the center, which denotes gas in the small intestine, and there are gas shadows also in the periphery, right side, mid upper parts, midline, and in the left denotes also gas in large bowel. Okay, so how could we know that this is normal or abnormal dilatation? You should have a ruler and you should measure the dilatation, the segment dilated from one side of the wall to the other. If it follows 369 centimeter rule, then this is normal dilatation with gas shadows. If it is beyond that, beyond 3 for small intestine, 6 for any part of the colon, and 9 for the cecum exclusively, then that is large bowel obstruction or small bowel obstruction according to the part dilated. Okay, again, the large bowel is actually having its own version of a string of pearls sign. But here the pearls are larger because Plica semilunaris are larger and they contain more air inside their buckets. So it tends to be larger than those of the small intestine. And as we mentioned before, it's less likely to be peripherally distributed, except in the transverse colon. It will be crossing from one side to another, denoting dilatation in the transverse colon. And of course, any string of pearls sign, small or large, will denote small or large bowel obstruction. So this is the difference between string of pearls sign, the upper films in the small bowel, and the lower films in the large bowel, in both the erect and supine positions. String of pearls sign are very clearly seen on the films to the right, above and down. Okay, now you should know that large bowel obstruction constitutes a quarter of all cases with intestinal obstruction. In this film, as you can see, there is dilatation of the cecum and ascending colon. The diameter dilated diameter of dilated part of the bowel extends beyond the normal boundaries, beyond 9 centimeters for the cecum. So this denotes that the obstruction is distal to this dilated segment. So maybe the patient's having well, actually, the transverse colon is also dilated, as you may follow the gaseous shadow there, and maybe on the left side, around the arrows, there'll be some shadow of feces or mass. So there is obstruction on the left side, causing dilatation of the transverse colon and of the cecum as well. So you should also know that when the cecal diameter is beyond 10 centimeters, the probability of perforation, cecal perforation, is high. And of course, cecum always dilates to the largest extent, no matter where the large bowel obstruction is sited, and that's according to Laplace's law that you may have had an idea about in physics in secondary school and so on. So let's take this case of a patient presented with Aquarian style obstruction. He's had this plain X-ray film. If you want to comment on this film, this is going to be plain abdominal X-ray showing abnormal gas distribution in the colon, and there is distension, or there is increased gas shadows or gas shadow densities in the midline to the outer parts and on the right side. So the transverse colon is dilated and the diameter there is more than 6, it's about 7.6 or so, and as well as the cecum is also dilated beyond 9 centimeters. So both are dilated, both segments are dilated, which denotes more distal obstruction with this proximal dilatation. Actually, this case is a case of large bowel obstruction, and when we followed up with this patient with further investigations, he underwent barium enema, which is seen here. So this is no longer a plain X-ray. This is an X-ray with dye, and as you can see, the barium takes the whitish shadow or whitish density. So it's injected rectum, and the sigmoid is showing a proximal obstruction or arrest of the dye, so the dye or barium cannot pass beyond the sigmoid mid part, or maybe the proximal part of the sigmoid. So this denotes sigmoid obstruction or obstruction of the sigmoid, maybe or most probably sigmoid cancer. And so, as you've seen with the previous films, the patient would have dilatation of the bowel proximal to this sigmoid. That's why his transverse colon and cecum or ascending colon are maximally dilated. Okay, let's get other views of large bowel obstruction with certain pathologies like volvulus. As you'll know, volvulus is rotation of the gut around its mesentery. Like in this film, it shows a shadow of hugely dilated part of the bowel, extends in the right upper abdomen. And in better films, it would have shown a sign called coffee bean sign. We'll get to that in a minute. But I want to also to notice that his left femur is having a prosthesis. Okay, so maybe you may be encountered with strange structures in the film. Don't be puzzled by that. Okay, again, this is a plain X-ray of the abdomen showing parts of the abdomen and the pelvis. Okay, and it shows abnormally dilated bowel. Usually, this is the large bowel. That's denoted by the abnormal gas shadows within this bowel, and as you can see, usually this is the sigmoid that's usually dilated from pelvis and up into the upper abdomen. Inside the lumen, there are the plicae, which are widely spaced. This is not definitely not small intestinal lumen. This is large intestinal lumen. That's because of this one point. And another point is that the hostrations are incomplete. They do not cross from one side to another. Now this is a more clear view of a sigmoid volvulus. As we mentioned before, if the part of large bowel is maximally dilated or very much dilated, likely are no longer present, like this large gas-filled loop without hostie or septi. And this is actually a sign of coffee bean sign or inverted U-shaped sign, which denotes sigmoid dilatation and due to sigmoid volvulus. Again, this is coffee bean sign or inverted U-shaped sign of sigmoid volvulus in a plain abdominal X-ray film. Okay, this is the same sigmoid volvulus. It's very easy, actually, spot diagnosis, but you should mention the whole. Points. So start with the type of the film, the view, what does it show normally, and then the abnormal finding, and you should end with the most probable diagnosis or provisional diagnosis. Okay, we'll skip that for a minute. So that was the abnormal gas pattern inside the lumen. So about the abnormal gas pattern outside the lumen of small or large bowel. So we'll be talking about free air inside the peritoneal cavity, or in other words, pneumoperitoneum. It's actually one of the most important signs in radiology and in medicine. If you missed it, the patient may die. So it's very important that you concentrate on if you're expecting a patient with perforated viscous, you must concentrate on finding signs of pneumoperitoneum. Differential diagnosis of pneumoperitoneum is very well known, mostly with perforated viscous penetrating trauma that penetrates inside part of the bowel, causing escape of air, any ruptured or perforated inflammatory bowels, malignant bowels or malignant lesions, and even it could be seen after laparotomy or laparoscopy, of course, and even after peritoneal dialysis or gynecologic procedures like vaginal insufflation. Vaginal insufflation, this one, I think this one is done with hysteroscopy and so on, and of course with other non-abdominal causes like bronchopleural fistula and non-invasive BAB, that is chest problem associated with those intubated patients. There are also causes of gas inside the biliary tree. You should know this differential diagnosis. So let's get back to the signs of pneumoperitoneum. Well, there are many signs: the anterior space air, dog's cap sign, regular sign, a football sign, the air under diaphragm and erect film. This is the most important actually. So we'll be discussing now the pneumoperitoneum, which is actually seen in erect films, as we mentioned, to see air underneath a fluid level, or with the fluid level underneath, then the patient should be in the erect position. So we'll be discussing this first thing, the air under diaphragm, the erect position, because this is the most important sign of pneumoperitoneum. Okay, we'll skip that. Let's get to this film. If you've been given this film, now we're talking about air under diaphragm. So there's no value of filming the abdomen. Okay, so if you want to interpret this film, so you'd say that this is a plain chest X-ray showing the chest and the upper abdomen. It shows normally on the left side air inside the stomach, or maybe, and on the right side that's abnormal. There is air under the right copula of the diaphragm. So the next question is going to be, what's your differential diagnosis? So you should know the causes of air under diaphragm, or in other words, causes of pneumoperitoneum the ones that we've mentioned before, most importantly, perforated viscous, perforated inflammatory or malignant bowels after laparoscopy or laboratory, and so on. Sometimes you may be encountered with such a film. This is a plain chest X-ray with heart shadow in the middle, so to the left. So on the left there is minimal air seen on the left, but on the right there's actually some gaseous shadows. So this is pneumoperitoneum or air under diaphragm denotes pneumoperitoneum. Let's skip this one. Okay, and this one as well. Okay, sometimes you may be encountered with a plain X-ray of the abdomen with in a child or an infant actually, and this is known from the small vertebrae and the very small ribs that the film has or shows. This film shows linear streaks of intramural gas or gas within the bowel wall, not inside the human, but is within the wall of the bowel, and this denotes infarction of this bowel wall. This is called a condition called Regler's sign, and it's seen in cases of NEC or necrotizing enterocolitis. It's called also pneumatosis coli. Again, regular sign is seen in a child with a plain abdominal X-ray, and it denotes a bowel wall infarction with air inside the bowel wall, not in the human. And this is positive regular sign denoting necrotizing enterocolitis. So that ends our talk about the abnormal gas patterns. If you want to review the calcifications that may be abnormally found in a plain abdominal X-ray, then it's okay. I'm going to skip that because actually it's not related to cancer processes. So let's skip that and let's get to the next point in our lecture. Another view of a man who had a bottle inserted rectum, and actually he tried to fish it out with a hook, and both got stuck. And he came to the emergency department again, and they extracted both of them. Okay. This is another film. It has an interesting story. A man from New Mexico. He plans to propose to his girlfriend, and he slipped um, a ring in her milkshake, thinking that she can feel it in her mouth, and she sips the milkshake, but actually she swallowed it, and it was in her stomach. It was extracted safely with upper GI endoscopy. And this man was a smuggler. He was arrested in prison, and he had signs of abdominal pain and so on, and bleeding. And on X-ray film, it has shown that there is a phone smuggled in his rectum. He didn't want to lose contact to the outside world. Unbelievably, this live hand grenade was swallowed by a terrorist. But actually, I think this is a Photoshop because there is no hot shadow here. So I think this is a joke. Okay. Do the CT or CAT scan of the abdomen and pelvis. You should have an idea about the CT of the abdomen and pelvis. You should know the different shadows of different organs in the abdomen. It's fun actually. You can read it by yourself. Okay, I'm not going to illustrate the structures seen in CT and abdomen pelvis, but maybe in the TA we might discuss some points there. I want to stop at the CT colonography because this is an important step in managing patients with suspected colorectal carcinoma. As we've mentioned before, CTC is ordered when there is incomplete colonoscopy. And when you're having a patient with whatever mass in any part of the colon, but the colonoscope cannot pass beyond this mass, and you want to assess the rest of the bowel. So you have two options, either CTC or BILCAM. BILCAM is not widely available in Egypt. I think it's in Cairo only, in some centers in Mansoura. One center in Mansoura might bring it. It's very expensive, so we use CTC instead. And as we've mentioned before, CTC is it's like the normal CT, but with special software that puts images together and makes or forms with the serial cuts of the CT film. It forms an image of the bowel from inside. CTC sensitivity is for tumors more than 9 millimeters. But smaller lesions are better seen with colonoscopy. So this is a lesion, or actually there are multiple polyps in here. This is a single lesion or polyp. I think in the splenic flexure maybe. Okay, and these are multiple polyps seen on the CTC film on the left, and on the right this is normal CT. And actually carcinoma can also be seen or demonstrated, like in this CTC rendered image on the right, the apple core appearance, an axial cut from a CTC. This is the inside view of this huge mass causing the apple core appearance. MRI abdomen and pelvis has some indications, and actually it has advantages and disadvantages. but we usually do not order MRI abdomen for colonic cancer. We can order it for pelvic tumors, actually, um, pelvic and rectal and anal canal tumors. This is normal anal canal, and supposedly the point in the middle that's marked with the mucosa, this should be marking the rectum, rectal mucosa, and the ischioctal fossae are to the left and right. If the center of the field or of the MRI image is filled with a mass, then this would indicate a rectal tumor according to its position to the pelvic structures. So this mass is a low rectal tumor. MRI would give us an idea about the T stage, the N stage, if there are any perirectal lymph nodes present, and sometimes if the radiologist is expert enough, he will tell us if there is extramural vascular invasion or not, with the vessels, lateral vessels, getting into the mesorectum, if they are containing densities or tumor tissues within. And also to better demonstrate the rectum and rectal lesions, you may be encountered the term of EOS, or endoluminal ultrasound. It's actually not just for the rectum, it's also for assessment of esophageal lesions and pancreatic lesions with the ERCP. So it detects smaller lesions or small lesions smaller than 1 centimeter. It assesses the transmural involvement of the tumor, that's the T stage. It assesses lymph nodes around the tumor, that's the N stage, and it also assesses the surrounding soft tissue. And in the rectum, we're concerned with the internal anal sphincter because its compromise would alter the management, as well as the mesorectum involvement as well. So we've had an overview of an X-ray without dye or plain X-ray of the abdomen, and we have an idea about the CTC, MRI, and EOS. The remainder of the topics will be discussed in the next lecture, inshallah. Thank you for listening and following, and these are my contact details. We'll see you around, inshallah. Shukran. Assalamu alaikum wa rahmatullah.